From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this JAMA Clinical Reviews podcast. This is Dr. Ann Cappola, Associate Editor for JAMA and Professor of Medicine at the Perelman School of Medicine and Director of the Penn Medical Communication Research Institute. Today, I'm joined by Dr. Elizabeth Shane, Professor of Medicine at Columbia University Irving Medical Center. We will be discussing her review article entitled Hypercalcemia, a Review. Elizabeth, thank you so much for joining us and welcome.
Well, thank you very much for having me. I was so honored to be invited to write the article, and I'm very honored also that it's been selected for a podcast.
So I'm going to start with what should be a straightforward question, but perhaps it's not. How do you define hypercalcemia?
I think it really is quite straightforward. Hypercalcemia is defined according to the measuring laboratory's normal range. So if the albumin-corrected serum calcium is above the upper normal limit, that is considered hypercalcemia. There really isn't any universally accepted upper normal limit that would be the same in each and every laboratory. So you can't really talk about a physiologic upper normal limit because it's just so different from place to place. In practice, this is really only a problem when the albumin-corrected serum calcium is near the upper limit of normal. Obviously, if you have a serum calcium of 12 milligrams per deciliter, that would be abnormal in any laboratory. But a serum calcium of 10.2 milligrams per deciliter could be abnormal in your laboratory, but might not be in my laboratory. So it's a little straightforward, but maybe not so straightforward.
By and large, we should be just looking for the H next to it, but also paying attention to the albumin level.
Yes.
Now, are there situations where we should be measuring the ionized calcium level?
Well, usually the measuring total serum calcium is enough. But if the serum albumin is low, then you can correct it using the widely used algorithms that have been in use for many years. Using it for an elevated albumin is not as well accepted. So when the albumin is high, that may not be quite as accurate as when the albumin is low. I think that the use of an ionized calcium is particularly helpful when there's a lot going on. If you have a patient in the ICU who has disturbances in albumin levels and acid-base problems, then an ionized calcium may be quite helpful, particularly when the patient has an acid-base abnormality that affects the binding of calcium ions to albumin. And therefore, you can't really tell from the total calcium what is going on with the ionized calcium. So then I think if it's available, it's very useful to get an ionized calcium.
So would it be fair to say that by and large in outpatients, you're not recommending measuring ionized calcium levels?
Yes, I think that's fair to say. In outpatients, you probably don't need to do that, especially if they don't have chronic metabolic acidosis or alkalosis.
Now, people are getting lots of these calcium levels because they're now part of the basic metabolic panel or the comprehensive metabolic panel. And sometimes, at least I've seen that there's some fluctuations. It's not always above the 10.3 or 10.2, whatever the range is for the assay. You can see a little bit of fluctuation. Would you recommend generally looking for persistence of abnormalities there? Or what do you do in the patient where there is some fluctuation between the high 9s and the low 10s?
Well, then I usually follow that patient over time and try and get a sense of what they usually are. Lots of patients with fairly consistent hypercalcemia will have the odd day when they're normal, and conversely, perhaps less commonly, people may have mostly normal, but the occasional elevated calcium level. And so I think that it's fine because usually these levels are around the upper limit of the normal range, in and out of that normal range. And I think that that's not a dangerous level. So it's usually safe to follow them until the situation eventually declares itself one way or the other.
Now, this may seem like somewhat of a basic question, but why do we even worry about hypercalcemia? Why does it need to be managed?
I don't necessarily think it always needs to be treated, but I always think it's important to try and figure out why the patient has hypercalcemia, because it may be an early sign of an underlying undiagnosed problem. For example, vitamin D toxicity or multiple myeloma that the patient is unaware of. And so therefore, I think it's something that should be taken seriously in terms of why the patient does have an elevated calcium, but it doesn't necessarily need to be treated, particularly if it's mild. Severe hypercalcemia, though, is kind of a different situation. And even if we're dealing with moderate hypercalcemia that is developed rapidly, I think that should be treated because it's often very uncomfortable for the patient. The patient has symptoms, polydipsia, polyuria, gastrointestinal symptoms. And if it's high enough, it can be life-threatening, for example, if mental status is altered or cardiac arrhythmias develop. So I think in those situations, it is important to treat it.
Now, certainly, you've just described situations where universally there's some complication from it, and that would require urgent evaluation and management. Is it always based on what the clinical situation of the patient is, or are there absolute levels where you're worried just based on the level that something needs to be done more urgently?
Generally, we think of a serum calcium of, say, 14 milligrams per deciliter as getting into the dangerous range, and it should prompt treatment immediately, with evaluation proceeding concomitantly with treatment. Like if the patient suddenly presents with a calcium of 14, I would begin treating while I was thinking about why the patient was hypercalcemic. That being said, though, some patients have debilitating or worrisome symptoms even at lower levels. And in those patients, urgent treatment should be initiated even if it's below 14. I'm not talking about 10.5 here, I'm talking about 12.9 or 13.2. And then conversely, you can have some patients who will come in with a calcium of 18 milligrams per deciliter, and they'll be completely asymptomatic. Now, I still treat them because it's scarily high, but I might take a somewhat less aggressive approach. It generally seems to have to do with the relative chronicity or acuity with which the hypercalcemia develops. So if it developed rapidly, the patient tends to be much more symptomatic. Some patients have had hypercalcemia for years, such as patients with parathyroid cancer, and they may be used or have accommodated to the hypercalcemia. So in those patients, it may not be so alarming and they may be asymptomatic. But generally, 14 is the reasonably acceptable cutoff for when you want to jump in with more aggressive treatment.
And in terms of the symptoms to worry about in those that may have calciums in the high 12s or in the 13s range, what are some of the symptoms that would alert you that that would be due to the high calcium potentially and therefore reversible with treatment?
Well, polydipsia and polyuria tend to be among the first, and also GI symptoms like nausea, vomiting, constipation. The things that are more alarming are mental status changes like a stupor, coma, maybe just a little difficulty in concentrating is a little subjective, so it's a little bit hard to hold your hat on that. But I think that anything more than decreased concentration ability should prompt therapy. And then, of course, the EKG with a long PR interval or arrhythmias, that's also very concerning.
All right, well, let's take a step back and let's just talk broadly about a patient that you see in front of you that has hypercalcemia. What is the standard evaluation? And then we can move to management. But what's the standard evaluation for a patient who presents with hypercalcemia?
That kind of depends on whether it is mild and or long-standing or whether it's severe. If you're dealing with a patient with mild hypercalcemia, then the appropriate approach is to take a detailed history, including review of old labs to determine whether this has been there for a while and just hasn't been acted upon or noticed, or whether it's a new event. And also a medication history to make sure that the patient isn't on excessive thyroid hormone or thiazide diuretics or taking excess numbers of supplements, particularly vitamin D and less commonly vitamin A. So I think an important thing always is the history. And then it's also essential to perform a good physical exam, looking for clues such as lymphadenopathy or some such physical trait that might point you in the direction of, say, neoplasm versus something benign. In terms of the diagnostic workup, the first step is really to measure PTH level and a serum calcium level at the same time on the same blood sample. If the PTH is high, or if it is normal but well within the normal range, the upper end or mid-normal range, then the diagnosis is probably primary hyperparathyroidism. If that patient is young or has a positive family history of hypercalcemia, it may be worthwhile considering genetic causes such as familial hypocalciuric hypercalcemia, which is better known as FHH. That would be the most common of those genetic causes, although it's still pretty rare. If the parathyroid hormone level is frankly suppressed, or if it's at the very lower end of the normal range, then it's important to consider other causes: thyrotoxicosis, vitamin D toxicity, malignancy. There's a whole multiple tables in the literature of common and not so common causes of hypercalcemia. But I think those are the things to be considering when you're evaluating a hypercalcemic patient. If the hypercalcemia is severe or of rapid onset, most likely the patient has malignancy, although this isn't really certain by any means. So I think that it's important in such patients to then focus on diagnosing the type of malignancy as indicated by the history, physical, and targeted imaging and laboratory tests.
So it sounds like history and physical. Next step is to check the PTH, and the big decision point is about whether it's parathyroid hormone mediated or not. If it is parathyroid hormone mediated, then what are the next steps for the patient?
Once you know that the patient has parathyroid hormone mediated hypercalcemia, the next step is to evaluate them to determine, again, just occasionally the patient may have a familial form of hyperparathyroidism. Also, not to be forgotten, are rare reports of certain malignancies that actually secrete parathyroid hormone. But these are a tiny, tiny, tiny proportion of the vast majority. So I think that once you have made the diagnosis of primary hyperparathyroidism and you're secure in that diagnosis, then I think the next step in my mind is to determine whether the patient meets the guidelines for recommending parathyroid surgery. Those guidelines would be whether the patient has symptomatic hyperparathyroidism, i.e., they have symptoms of hypercalcemia or a history or a current kidney stone or nephrocalcinosis or hyperparathyroid bone disease, which is osteitis fibrosis cystica. Now, that's pretty unusual in this day and age, and particularly in developed countries. So usually we don't see that, probably less than 5% of cases. If the patient is not symptomatic in any of these ways, then the next question would be, do they meet other guidelines for surgery? To figure that out, you need to have the serum calcium, which should be, as a guideline for surgery, 1 milligram above the upper limit of normal is one of the guidelines. You need to do a creatinine clearance, because creatinine clearances below 60 are an indication for surgery. And a 24-hour urine calcium should also be done, because a level above 250 milligrams in women and 300 milligrams in men per 24 hours is one of the guidelines for surgery. It's also important to be sure that the patient does not have kidney stones or nephrocalcinosis, so it's important to do an ultrasound or other abdominal imaging to rule out those issues. And it's also important to know that they do not have osteoporosis. So you get a DEXA scan to measure their T-score and also image their vertebral spine to make sure that they don't have vertebral fractures. And you can do that either with a vertebral fracture analysis with the DEXA, if you have that capability, or you can get spine films. So if all of those things are negative, then you can probably follow the patient over time as opposed to operate.
So if I hear you correctly, Elizabeth, the next step would be to have some laboratory evaluations that would include a 24-hour urine, which is not something that any patient likes to do, but is an incredibly useful test in this situation,
Yes.
as well as potentially some other imaging that might be required to really see if any of the criteria are met for surgery. And is age also a criterion in there?
Yes. If the patient is under age 50, that is an indication for recommending parathyroidectomy.
What if you have a patient that says they have reflux symptoms and constipation and difficulty concentrating, but none of the biochemical or radiologic evaluation meets criteria for surgery and they don't meet the age cutoff? Is that someone that would go to surgery, or do they get monitored unless they specifically meet those more objective criteria that are part of the guidelines?
Well, let me say you can also recommend surgery for patients who do not meet guidelines. And patients who do not meet guidelines can also request to have surgery. So I think the types of symptoms that you've described are very nondescript symptoms. And I think it's highly likely that a patient with constipation and a calcium under 1 milligram per deciliter, higher above the upper limit of normal, so within 1 milligram per deciliter, it'd probably still be constipated even after the surgery. So I think you don't want to set up a situation where mild, widely experienced signs and symptoms are attributed to hyperparathyroidism when they may just be part of the way the patient is. So I don't think you could really assure the patient or be sure yourself that after they had the surgery, those things were going to get better.
You and I are fortunate enough to be at institutions where we have very experienced parathyroid surgeons. Can you talk a little bit about what someone should look for in a parathyroid surgeon?
I think you should look for somebody who is very experienced in doing these. You don't want somebody who does a couple of these a year doing your parathyroid surgery. You want somebody who is at a place where they do this all the time. So I think the volume and experience of a surgeon are very important.
I would absolutely agree because hypoparathyroidism is a hard complication to manage on the other side. So much better to have someone that has the appropriate number and amount of parathyroid tissue removed, as well as making sure that there's cure afterwards. It can be very satisfying when it's a solitary adenoma. There's cure afterwards. Much of what we manage in endocrinology doesn't have a cure at the end of it. So that's just one of the more satisfying things.
And we would like to diminish that need to manage those patients who haven't had a successful outcome by making sure that within our power, the patients go to people with the most experience.
Now, some patients don't want surgery and they ask about medication. Is medical therapy an option for someone with primary hyperparathyroidism?
I tend to not use a lot of medications to lower serum calcium. The main medication to do that is cinacalcet, which is a calcium sensing receptor agonist. And it can lower serum calcium into the normal range in patients with primary hyperparathyroidism, but I tend to avoid it because it's expensive and has side effects like nausea. And I wouldn't use it unless the hypercalcemia was moderate, symptomatic, and the patient either refused or could not undergo surgery for some health related reason, some physical reason. I think my tendency is to try and look for reasons to recommend surgery because I feel that this is a treatable disease and the long-term consequences are unclear. But we do know from some small studies, but some studies, that over 10 to 15 years, almost 40% of people with hyperparathyroidism are going to develop a surgical indication, such as a kidney stone or a more markedly elevated serum calcium. And for that reason, I always tend to recommend surgery as opposed to observation, reasoning that it's better to operate when the patient's younger and healthier rather than 10 to 15 years later when there's a good chance that they may not be as stellar a surgical candidate.
Does the patient have to be worried about having parathyroid cancer?
Parathyroid cancer is fairly rare. It tends to be associated with some characteristics, such as a very high serum calcium and a very high parathyroid hormone level and a palpable neck mass. Those are the most defining characteristics. I have seen it in people who had relatively mild hypercalcemia, but most of the time, if the serum calcium is not very high, say less than 14, and the parathyroid hormone level is within a couple of times the upper limit of normal, that's pretty unlikely. It does occur, and when I do suspect it, I alert the surgeon that I do suspect it because they would want to perhaps change their approach to the surgery and make sure that no biopsies were done and that they were very careful about evaluating the surgical characteristics of the pathological characteristics and the characteristics of the tumor as they view it when they're looking at it in the surgery.
Let's turn to the patient who does not have PTH mediated hypercalcemia. And let's talk specifically about patients who have hypercalcemia of malignancy. Can you talk a little bit about the evaluation or management in those patients?
If you have a patient who has hypercalcemia and a low PTH and they don't have a known malignancy, you evaluate them for common malignancies associated with hypercalcemia, such as breast cancer, renal cell cancer, multiple myeloma. But it's also important to consider some non-PTH dependent and non-malignant causes that could be associated with hypercalcemia, like as thyrotoxicosis, although that's usually mild, vitamin D toxicity. You can have very highly elevated serum calcium levels, and you'd need to get vitamin D levels to make the diagnosis of that. Milk alkali syndrome, and to evaluate those patients first before you do a huge malignancy workup with thyroid function tests, vitamin D levels, etc. If a patient has a low parathyroid hormone and a known malignancy, and they could still have other etiologies that could be contributing to or even causing the hypercalcemia, once you've excluded them, I think the focus then shifts to a collaboration with our oncology colleagues. We would want to control the malignancy as much as possible if it's certain that they have this malignancy and that it is that malignancy that is causing the hypercalcemia. And also a more chronic focus on how to manage the patient to control the serum calcium over time. Generally, this is not a good sign, and it usually means that the prognosis is limited, but we want to do the best we can to keep every patient comfortable and under control with hypercalcemia of malignancy.
And do you want to just briefly mention some of the therapies for those where it's severe enough? So I'm talking about inpatients who have hypercalcemia of malignancy that's in that urgent range that we discussed earlier.
So we often get consulted for this. So hypercalcemia of malignancy, or a patient comes in very hypercalcemic, and usually that patient is very volume depleted. So we always begin with aggressive hydration with saline. Generally, we try to avoid loop diuretics, although often on the consult service, we will see them given anyway. And the reason is the patient is already volume depleted, and you can just create a negative feedback loop by also giving them a powerful diuretic, and it can limit your ability to rehydrate them. So we try to stay away from loop diuretics until after the patient is hydrated appropriately, and then only if there's some need for the loop diuretic, such as the patient has an issue with renal insufficiency or heart failure or fluid overload. We usually, if the patient is very hypercalcemic and symptomatic, we often will give salmon calcitonin for a couple of days because it acts very quickly to inhibit osteoclast-mediated bone resorption, and it also increases urinary calcium excretion. And so for a couple of days, while saline hydration and bisphosphonates, which I'll come to in a minute, are taking to work, we can sometimes lower the serum calcium a little bit by a milligram or two with salmon calcitonin. We only give it for a couple of days because after that point, tachyphylaxis ensues and it's not effective. We usually give intravenous bisphosphonates, most typically zoledronic acid for hypercalcemia of malignancy, usually a dose of 4 to 5 milligrams intravenously, typically over 15 minutes. And that takes probably 36 to 48 hours to lower the serum calcium, which is why we hop in with the calcitonin at first. That is the typical approach to marked hypercalcemia in a patient with hypercalcemia of malignancy. This is new onset. I mean, if a patient has recurrent, then you might set up something where they get sequential doses of zoledronic acid as their serum calcium starts to come up again.
You mentioned that the treatment is aggressive hydration because they're all dehydrated, followed by calcitonin and then bisphosphonates. What about denosumab? Does that ever have a role in the treatment of acute hypercalcemia that's severe?
Well, there are not a lot of data on this, but denosumab has been useful in parathyroid crisis and parathyroid carcinoma, and it has been shown to lower serum calcium in patients with hypercalcemia of malignancy who are refractory to high IV bisphosphonates. And for that reason, it was approved by the FDA. The other place where we consider denosumab is in the patient who has an elevated serum creatinine or acute kidney injury or chronic kidney injury, because it is not cleared by the kidney and it does not cause further deterioration of kidney function. Unfortunately, there's not any data to tell us when one might be better off using denosumab than intravenous bisphosphonates. I use it in patients who have a high creatinine level. If I know the kidney problem was present before the hypercalcemia, the approved dose is 120 milligrams, and I usually start with a lower dose. And the reason for that is there's a concern for hypocalcemia that is worse with denosumab than with IV bisphosphonates.
Great. Thanks for that clarification. Before we wrap up, is there anything else that you'd like our listeners to know about hypercalcemia and its management?
I do think it's important to understand that it's particularly if it's consistent, hypercalcemia almost always signifies that something is amiss with that patient. And so therefore, it's important to take it seriously. I also think we didn't really touch on how to follow the patient with primary hyperparathyroidism who elects or does not have surgery. And they can be followed, but they should be followed with annual serum calciums, annual estimates of their kidney function. They should have bone density every year or every 2 years, and spine imaging to make sure they haven't had any fractures, and 24-hour urine calcium if it's indicated clinically. So those would be my points. You can follow patients with primary hyperparathyroidism successfully, and that's how to do it. And don't ignore hypercalcemia because it usually means something is amiss with the patient.
Great. I think that's a great way to wrap up. Thank you so much. That was Dr. Elizabeth Shane from Columbia University. This has been Dr. Ann Cappola with JAMA. This episode was produced by Jesse McQuarters at the JAMA Network. The audio team here also includes Daniel Morrow, Shelley Steffens, Lisa Harden, Audrey Foreman, and Mary Lynn Ferkulik. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.